As a featured part of our Heart Rhythm TV update from the front lines across Asia, we had a roundtable discussion to bring together the leaders of EP representing their country, their cities, their provinces, and their hospitals across Asia. And with Andrea Russo, we had a great question and answer roundtable discussion where we learned a tremendous amount about the methods to mitigate and contain and how to move forward and get back to life as normal after the peak of the pandemic. Here are the selected highlights that I found particularly useful. So it sounds like testing was not as much of an issue in China because there was a lower incidence. You know, we're hearing 500, 600 per province, which is so low compared relative to what we're seeing in the States. How long did the testing take to turn around? Because clearly you were able to do the nasal swabs like everyone's saying, but how long was the typical turnaround at your various centers?
4 hours in our center.
Oh, so that was very fast, because in the US, we are having sometimes that are 3 or 4 days still for testing.
3 or 4 days?
Yes.
No. In our hospital, 6 hours. Yeah.
Not very quick. Several hours.
Okay. So, and that was from day one, that the testing never took longer than 10 or 12 hours, correct?
So we tested twice a day. In the morning you test, then the afternoon you can have the result. In the afternoon, the next morning you can have the result.
Was there any need to re-sterilize N95? And if there were there any tips? UV, steam, autoclave?
Here is only single use, because I think the material of the 95 is not suitable for this sterilizing. I think maybe some new material is okay, but old material I don't think is okay for this sterilizing.
Any other comments? I saw a couple Twitter posts where some people were hanging them up next to a UV light, but you have not been doing that in your institutions?
No experience.
Can you comment on KN95? We've been having some shipments from China from colleagues trying to help out, and they're labeled KN95. Can anyone comment and educate us on KN95?
I think the safety level for KN95 could be used in clinical settings, especially even for physicians working in the front line.
Any other comments on KN95?
I think it's compatible to N95. It's a Chinese standard.
Yeah, Chinese standard.
It's
almost the same as N95, almost the same. But I don't know do you think about it? Yeah, we think KN95 is also very useful. Yeah.
So we're talking about masking. Dr. Liu, can you comment on whether a double mask is useful? KN95s, are they okay for the front line?
Yes. During the epidemic time in Wuhan, the Chinese KN95 is allowed to use in front line in the wards specific for COVID-19. It's almost the same.
There have been published studies showing non-inferiority compared to N95?
No, we don't have the study, but we believe our government.
Okay. And as far as double masking, a regular 2 surgical masks, do you have some words of caution as to why not to use double mask?
Yeah, double mask is not that safe, because when you have 2 masks, the air goes into your nose, maybe from the around of your mask, not directly through the mask.
Okay. So then if you double mask, you have more leaks.
Yeah, you have more leaks. The air cannot goes free through the mask, but leak in the mask.
Now, sometimes because we're having a shortage of N95 in the US, and the frontline workers will only get 1 a day, and sometimes we're reusing again, they're advocating putting a regular surgical mask over the N95. Do you think?
No, it's not. No.
You think that's also a bad idea?
No. It's bad idea. You cannot use in that way.
Okay.
Only one, yeah.
Only one mask, surgical mask or N95 mask is okay. Don't use two masks.
I don't know if Andrea, if you've seen that as well, but many people are trying to save the N95 by wearing.
That's actually what they're recommending at our hospital, to save it for future use. And but I hear the recommendations.
We're here to learn, and I think that's an important difference of opinions and seeing. Obviously, we're in a time where there's no prospective studies to show that, but that's an important pearl to get from Dr. Liu, who's obviously at the epicenter of the outbreak. The other questions that a lot of the Heart Rhythm Society community had was that of heart block. Of the patients that are infected, how many, what I've learned here is that a lot of the VTVF was in the end stages during codes, during ACLS, or during resuscitation. Sometimes you see people with hypoxemia that have problems on the ventilator and they get temporary vagal or heart block, right? So the threshold for implanting, permanent pacemakers should be much higher in the COVID patients. Did you have anyone have any experience in just waiting and seeing and trying to avoid pacemaker implantation in COVID patients? Or did you have to implant for a certain amount of patients? Dr. Liu?
Yeah. In January to February, these 2 months, I did 2 pacemakers for patients with heart block because they had syncope or over the time. So we have to do it to save their lives.
And they were COVID patients?
Yeah.
I see. And then when you implanted them, you just wore you wore an N95 for all the COVID patients?
No, we have protect ourselves by level 3. We have to use N95. We have the masks. We have the glasses, and then we have the whole set of protection shoes.
Yeah, unfortunately, our level 3 in the United States looks very different from even that of Europe and Asia, where I'm seeing pictures in Europe where everything's hooded, it's one, and we really typically have gowns and then protection, and that's it. So it's very different, the American crisis with the shortage of supply. The other question is, it sounds to me, you have Donald Trump and our president talking about hydroxychloroquine and how we're doing a lot of the studies here. It sounds like chloroquine and hydroxychloroquine are not widely used in China currently. And since you're all past it, you probably won't see any of these concerns for QT prolongation. That's all the rage right now in the United States. And, Dr. Ackerman from Mayo Clinic, and I saw one from Northwell as well. Everyone has their own QT algorithms, but it seems like that has not been a major issue at all in Asia, correct?
Yeah, we did not use chloroquine in our patients because we did not see much effectiveness for control the inflammation or the severity of illness. We don't see much. It cannot very help.
Does anyone else have any experience with steroids and vitamin C or plasmapheresis? Or hear of any of the experience of that?
The high dose of vitamin C is widely used in our hospital, especially for those patients with ARDS.
What doses are we talking about? Like, it's 10,000 milligrams IV, or what is the doses of that?
Yeah, I'm not very, very sure. We have to check, all right?
Yeah, I'm not aware that that's being done in the United States at all. Dr. Liu, I was really impressed with the idea that from your data that ACE inhibitors, not only should we not be fearing them, but we should actually be embracing them because it may be protective. We were very scared for a while about ACE inhibitors, and maybe we have to withdraw ACE inhibitors, but you're now suggesting with something in press that it may be protective because of competitive inhibition at the receptor level. Do you think it would ever get to a point where we would recommend ACE or ARB in non-hypertensive patients?
Yeah, if you give me a minute, I will show you the slides I just did for the ACEI and ARB paper. All right, 1 minute.
We have a preview.
Yeah.
This is Impress or not yet?
Not yet.
Okay.
And while you're getting that up, I was also really intrigued with the use of CT scanning for screening, and curious to know if most of you are doing that for screening patients when they come in the hospital, whether they're under investigation, patients who might have COVID, and then how long it takes for those CT scan results to get better. Is it something that improves in a few weeks if someone were positive?
Yes, I can answer this question. In my hospital, CT scan is very convenient. We can order CT scan very quick and to be get done. And the report will be available in 20 minutes. So it's really a convenient modality to screen patients. And according to the experience in our colleague by our colleague in Wuhan, the CT scan is very sensitive to screen patients with clinical diagnosed COVID-19 infection. So, and we do a lot of CT scan, and if chest lung are clear, make the patient and the surrounding safe.
And do you know how long it stays abnormal? If it's a prior infection, will that get better if they had an infection 3 months ago or 2 months ago?
Yeah, this is a good question. I think we need to do it combination with history. Did the patient have a history of prior infection of COVID-19 or no history? It's different. It's a different issue, and usually, according to some colleague, who dealing with treating patients with COVID-19, and the symptom and the CT manifestation is a very parallel or compatible with each other. So I think it's a very convenient, reliable test to rule out patients with COVID-19.
And that's a consensus within everyone here, Minglong, Yume, that CT scan is the first test for everyone.
Yes. Because CT scan here is very quick, and you can quickly have the results, and try to screen those asymptomatic patients, because the COVID-19 pneumonia is very unique. So the CT presentation is very unique. So even those patients, they do not have fever, maybe they already have the pneumonia, but this pneumonia, they have very specific, very unique CT presentation. So with this, you can quickly exclude those patients.
Yeah, I think what we don't know is what the denominator, like in everything here, is if you look at a random sampling, how many of COVID positive, how many have CT positive, or if there is some skew that you're identifying the patients with fever, with lower, symptoms with actual pneumonia, and those patients are more severe. I don't think we know the answer to that. We still don't even understand if there is a certain viral load that actually, a viral load predicts the severity of illness. And I know that that's something that has been very controversial, of why healthcare workers particularly have a worse course. We're seeing that in Europe and the United States, that the healthcare workers have worse disease. But I think it's interesting to draw from the China experience that maybe you're screening for the patients that are truly highly symptomatic, because you're finding patients with fever and then a positive CT. And that's a little bit different. Is there any asymptomatic testing that's being done in China to try to do a random sample to see what the incidence of asymptomatic is? Because it's hard to believe that of these provinces of 80 million, 100 million, that only 300 or 600 patients actually have COVID.
Rod, I tell you a story. That's the strategy here. You know, when one patient is diagnosed with the COVID-19, so every people has close connection with him, contact with the patient will be screened for COVID-19 infection, or at least will be observed for 14 days, for symptoms and testing. So by this way, we can screen many patients with asymptomatic symptoms.
So as Dr. Jiang said, Rod, so this is very clear. If someone is confirmed with COVID-19, so his activities will be posted. So the maybe within the 2 weeks. So if you take the bullet train, if you take the bus, if you drive to somewhere, because you will leave your personal information there, so all these information will be posted. So then those persons who you contact will also be informed to have the additional test, or you can be required to have home quarantine for 2 weeks.
And that's done through is that due through smartphone tracking of who they come?
Smartphone tracking. So because, if you buy a ticket, you will use your smartphone. Then you will leave your personal information.
Yeah.
And anyone that was on the same will be contacted, the same train or?
Yeah. They will be informed that someone you go with is confirmed with COVID-19, so you should stay at home for 2 weeks.
Do we have any sense of what the incidence of a COVID positive patient that goes home to quarantine, how often their family members get infected and how they do it? Sometimes it's a very small area. How do you keep them separate? Because Chen-Yang, you were saying that we can test the family to see how often.
Usually they are isolated in special hotel, not home.
I see. So
in the early days, because the like Wuhan, all the patients, this is quite beyond the capacity of medical treatment. So some of the patients, they will stay at home for home quarantine. But I think the 1 month after the breakout, all the patients, or even those asymptomatic patients, if you are confirmed, you will be put into the hospital or the special hotels. We have built some stadium hospitals to hold 1,000 patients there, but these are the mild patients, moderate patients.
Yeah.
Dr. Liu, do you want to share your ACEARB slide?
For patients with hypertension, the ACE, the level of ACE is decreased, and the level of the level of ACE2 is decreased, while the level of ACE is increased. So we all know that the increase of ACE will activate the RAS system, RAAA system. So it may have pathogenic effects. So it may induce inflammation, pulmonary injury, and myocardial injury. So when you get a COVID-19 infection, then the ACE2 level was decreased further, and the ACE level was increased level. So you get more serious cases when patient get hypertension. So if you have ACE, ACEI, and ARB, you may block ACE here and block the receptor here. And in another way, these two drugs will increase the level of ACE2. So the increase in ACE2 will get the protective effect. So in our correlate study, we found that the use of ACEI or ARB were decrease the requirement of respiratory supportive treatment, and the mortality just give increase. For the mortality just showed a decrease trend, but did not achieve significant difference. The p-level, the p-value is 0.11. So that's our primary result.
Are you able to show us those curves at all, or a difference of those outcomes?
The red curve is the patient not taking ACI or ARB. The blue curves is for the patient taking ACI or ARB. The mortality is almost significant difference, but the p-value cannot achieve significant difference. For this table, we compare the two groups, ACI ARB users and the non-ACI ARB users. You can see for the acute myocardial injury, it is decreased in ACI ARB users, see, 12%, and for the patients not using ACI ARB is 31%. This is for acute myocardial injury. And the total complication is decreased in ACI ARB users. For treatment, especially for mechanical ventilation here, you can see for ACI ARB users, the percentage is 19.4 and 39.8 for non-ACI ARB users. So we conclude that the ACI ARB users may have beneficial effects for COVID-19 infection.
That's great. Thank you for sharing that. We look forward to seeing that. That's coming out in European Heart Journal, Dr. Liu?
It's under review.
Oh, it's under review. Perfect. Okay.
And is that, those are people who are on pre-existing ACE inhibitors, ARBs, not started in the hospital? Is that correct?
These patients use ACIRB prior to admission, but and also use it during the hospital time.
Okay, great. Thank you.
So the last question I have is, there's been a lot of talk in the US about antibody testing and being able to see who has already, who's already has some immunity or, seroconverted. Is there any discussion of that in Asia and China about testing for antibodies and seeing which healthcare workers may need to be more at the front line, who needs to stay back, who comes back to work? Is there any role for that in Asia?
Yeah, we have to test antibodies for every staff who wants to go back to work, and test for every patient and their relatives looking after the patient. So we test antibody for almost everybody. So
it'll almost be universal antibody testing in Wuhan.
Yeah. It's very useful.
And do you already have that test available now?
Yeah, we test that almost, I may say 3 weeks ago.
Do you think that we're going to see that many more people will be IgG positive, have exposure, than the number of cases that we were seeing?
We do not count, but I believe what you said is correct.
And others, Ming Long and Dr. Long, Dr. Zhang, Dr. Shui?
Yeah, we also did the IgG test and IgM test. Yeah, but only those patients who were hospitalized. So before discharge, we will test the antibodies. So because our hospital, only had around 30 patients. So some of the patients, even they are recovered patients from COVID-19, their IgG is still negative. But most of them, so this for those mild patients, even they are discharged, but the IgG is negative. But for those patients with moderate or severe patients, their IgG is positive. So the more severe, the higher level the IgG is.
Let me just ask one other question. I noticed an earlier slide that might have been testing more than one time. So you'd get your COVID test, you'd have your CT scan for screening, and then you might test again before they come in for a procedure. What's your false negative rate, do you think, of the testing? Any thoughts? You know, it might be negative the first time, negative test the first time, and then positive the second time within a day or two.
Yeah, in the United States, many people suggest 2 tests for rule out. Were you having 2 tests required in Asia and China?
Yes, in our hospital, we make at least 2 times for each patient. We want to do the CT scan. We do the swab RT-PCR test, and we do the antibodies. So we combined all 3 tests together. If we have question, we have to ask the experts on this field to get their ideas.
Anecdotally, did you see many patients, can you remember them, that have normal tests but very abnormal CT scan? Was that common scenario?
It's not common. It's not common.
So you think the test was very sensitive in general with the nucleic acid nasal swab?
Yeah, we believe antibodies.
No, but I'm talking about the nucleic acid test. Do you think that's sensitive enough? Meaning, do we need in the United States and Europe to be doing routine CT scans?
Yeah.
You know, I think that you could make the case for CT if you have many people that are negative with the nucleic acid testing and the nasal swab, but their CT is positive, and then they eventually become positive. Is that a common scenario?
Very common.
Chen-Yang, you think that's very common?
Very common.
Where the CT is positive, but the testing is negative until later?
Yeah. I think in the early days in the Wuhan, Dr. Lu, some patients, even with the 3 times negative nucleic acid test and negative, but very severe symptoms and very obvious CT manifestations, very common. Even patient died from the disease. So the nucleic acid test is still negative.
Yeah, I understand. At the very early stage, we did see some patients with positive CT scan, but negative for several times with the swab RT-PCR test. But now we have antibodies. So we believe antibodies, especially for patients with IgM positive.
That's important. Thank you.
Great. And then with regard to amiodarone, many people in the United States are saying if you have VTVF or AFib, which we see with sepsis, SIRS, cytokine storm, is there any feeling that amiodarone should be avoided? Or have you been using amiodarone on the front lines for patients with AFib or VT?
We did have some patients with atrial fibrillation. So we use intravenous amiodarone. We don't afraid the side effect of amiodarone on the phenomenon.
So even if someone has ARDS,
we use amiodarone.
Using amiodarone.
Yeah, we use amiodarone.
Great. Well, I'd like to thank the whole panel and our global EP community for tuning in. This has really been a great process to be able to see the practice variation, to learn from each other. More importantly, to see that all of our friends in China, our leaders here, are happy and healthy and reporting that they're recovering. The things that I've learned, to summarize, is that the containment and mitigation was extraordinary in China. We're hearing numbers of 500, 600 out of 80 to 100 million. And we can only wish for something like that, where In the state of Illinois, we have 10,000 right now. In New York, we have over 100,000. So our situation is much more severe. And obviously that might be that the US has the most testing as well. But the things that I've learned today are, for our viewers that have tuned in, are that you might have tuned in for two reasons. One, to figure out why Asia has done such a great job in the United States or Europe or Latin America as well might not be doing as well. But number two, you might have tuned in to say, I want to get pearls on how to treat these patients for VT, AF, heart block, and all that. And what it sounds like is that fortunately, our Chinese physicians don't have that much of a need to have treated VT, VF, because the containment was so good. I think what's been really impressive is that we have such a different practice variation in America, where we don't have people at the front of the hospital with fever monitors, temperature, looking to see, and screening. That's your first point of triage, and we don't use that. And in the airports, that's not happening. There's no temperature sensing as a method of point of triage. And we do not do routine CT scanning in the States. I don't know if that's true in Latin America or in Europe, but that's not the standard process. And I think we need to learn from your success, that we need to strongly consider that the temperature and CT scan should be the first points in the decision tree. And that's something I've learned. The other thing is that the fear of ARB may not be a fear, but actually we need to embrace it and celebrate it. And thank you, Dr. Liu, for sharing that, as well as the message about troponin, that it's powerfully predictive, and that many patients that have positive troponin, their mortality is over 50%, whereas the ones that do not have positive troponin, and that's from two publications, yours, Dr. Liu, and another by Shi et al. In JAMA Cardiology, the mortality rate is less than 10% for those. So it is powerfully prognostic. And Dr. Zhang, I want to thank you for exposing us to the use of technology. And Dr. Long, you've been using technology to assist other electrophysiologists of how to do procedures when you can't physically be there. The only silver lining of this pandemic is it's letting us explore virtual. It's forcing us to explore virtual and what is essential and what's non-essential. And then Dr. Zhang, for you to show us how you have all of the citizens of your province that are logging into their smartphone and being able to be tagged as green, yellow, and red as low risk, medium risk, high risk. That's such an important, and I don't think that we have capitalized on the use of these digital platforms. I know people are using smartwatches, but we have not had that level of organization. So there's so much to learn from you. Thank you for sharing the time. We cannot wait to be with you face-to-face in person, but much respect and love to your loved ones as well. And thank you on behalf of Heart Rhythm Television, Heart Rhythm Society. Thank you, and it's great to see you.
Yeah, thank you so much.
Thank you.
Thank you.
Thank you.
Thank you. Take care. Take care. Be safe.